Assalamu alaikum, good afternoon, everybody. Thank you, Dr. Abdallah, for inviting me to this prestigious conference. And I'm really happy to share with you this presentation today about pulmonary embolism, the evolving advance and management. As we know, venous thromboembolism affects nearly 10 million people every year worldwide. And the most clinically significant subtype is the DVT and pulmonary embolism. By 3 months, there 14% of patients with proximal DVT and 17.5% patients with pulmonary embolism will have died. So it is a major health problem. What are the risk factors that predispose to VTE and hence pulmonary embolism? This is many risk factors. I'm dead sure that you know this factor better than me, like surgery, trauma, immobility, cancer, pregnancy, postpartum period, estrogen treatment, obesity, fracture, stroke. All these risk factors can predispose to pulmonary embolism and VTE. But the problem of the pulmonary embolism is the burden and the challenge in diagnosis, because usually the pulmonary embolism, most of the time you get it by exclusion. And those with clinical suspicion largely remain unconfirmed due to high mortality rate. And silent pulmonary embolism with a frequency of 40 to 50% occur in patients with DVT. So, how can we make a prediction for pulmonary embolism? We have two important clinical prediction criteria. Willis criteria, this comes from the latest guideline. It was have a different parameter. Each one has score point. This was the original version, and then we have the simplified version. And then the clinical probability classified according to 3-level score. Low, 0 to 1, or intermediate from 2 to 6, high from up 7 or equal to 7. And the 2-level score, pulmonary embolism unlikely 0 to 4, and the pulmonary embolism likely from more than 5. This is the first one that you make a clinical prediction. The second one, what we call the Geneva clinical prediction rule. Also, we have an original version, and in the latest guideline, it will be simplified from 2019, a simplified version. And the clinical probability, we have also 3-level score. Low from 0 to 3, intermediate from 4 to 10, high from more than 11. And the 2-level score, unlikely from 0 to 5, pulmonary embolism likely from more than 6 or equal than 6. And you have again what we call the pulmonary embolism severity index. This is very important. Also, we have original version and we have simplified version, and the risk strata classified. Class 1, less than 65 point, usually carry very low day mortality. Class 2, from 60 to 85, low mortality risk. Class 3, from 86 to 105, moderate mortality risk. Class 4, 105 to 125, high mortality risk. And the class 5, more than 125 pounds. So this is very important to make a clinical prediction of pulmonary embolism, because as we said, it's not easy to diagnose and it comes by always prediction. What are the classification of pulmonary embolism? We have what we call massive pulmonary embolism, which is characteristic by hemodynamic instability, where systolic blood pressure less than 90 for at least 15 minutes, and you take inotropic support. Submassive, it is acute pulmonary embolism without hypotension, and then we have low-risk pulmonary embolism. And as we know, the acute pulmonary embolism is related to the hypercoagulable state and the Virchow's triad. This is well known. We'll not lose our time for this one. And this is what happened for the acute massive pulmonary embolism. There is right ventricular volume overload, right ventricular dilatation, right ventricular wall tension increase. At the end, there is the reduction of oxygen delivery and the decreased coronary perfusion to right ventricle, and this will lead to obstructive shock. And would lead to what we call right ventricular dysfunction. What are the markers of right ventricular dysfunction? By echo, right ventricular dilatation, elevation of proBNP, elevation of N-terminal proBNP, ECG changes in the form of new right bundle branch block or anteroseptal ST elevation, and elevation of troponin more than 0.5 milligram. So what are the goals of management of pulmonary embolism? First of all, prevention of death from current pulmonary embolic event. Second, to reduce the chance of recurrent embolic event. Third, to minimize the long-term morbidity due to the event. What are the diagnostic tests of pulmonary embolism? The easiest one is D-dimer, of course. Then the ECG, we have shown right ventricular overload. We have a duplex ultrasonography, presence of DVT, X-ray chest, echocardiography, TROP-T and BNP, and of course, CT pulmonary angiography, which is considered the gold standard for visualizing the filling defect. So, if we look to the latest guideline 2019 European Society of Cardiology, we can find that D-dimer recommended as class 1A. probably using a high sensitivity assay, and it is easy. It is recommended in outpatient or in the emergency department. Again, this is the classification of pulmonary embolism at the latest guideline on early mortality risk. High is upper column high. You can find hemodynamic instability, clinical parameter of pulmonary embolism severity, RV dysfunction, and elevated cardiac troponin level. Intermediate high, just the same, but without hemodynamic instability. Intermediate low, also with clinical parameter of pulmonary embolism, plus or minus RV, the ventricular dysfunction or elevated cardiac troponin. Low, of course, assessment of optional if assessed negative. What are the treatment of acute pulmonary embolism? This is very important. Unfractionated heparin, low molecular weight heparin, fibrinolysis, direct oral anticoagulant NOAC, catheter direct thrombolysis, surgical thrombectomy, and IV filter. However, anticoagulation and the thrombolytic are the ministry of the medical treatment. Anticoagulation in high-risk patient with pulmonary embolism, anticoagulation with unfractionated heparin should be started without delay. We can use low molecular weight heparin or fondaparinux as recommended as the initial treatment for most patients with non-high-risk pulmonary embolism. So the recommendation, anticoagulation should be started as earlier for patients with intermediate or high clinical probability of pulmonary embolism and having no contraindication to anticoagulation. This is the dose of the low molecular weight and the fondaparinux. Then thrombolysis, which is one of the main cornerstone for patients of acute pulmonary embolism. This faster improvement in pulmonary obstruction, pulmonary artery pressure, pulmonary vascular resistance, improvement are accompanied by reduction in right ventricular dilatation on echocardiography, and greater benefit observed when the treatment initiated within 48 hours of symptom onset. However, it can be delayed from 6 to 14 days. The meta-analysis of thrombolysis trials that include patients with high-risk pulmonary embolism indicated a significant reduction in combined outcome of mortality and recurrent pulmonary embolism. This is a thrombolytic agent available, but I think now is available is the alteplase, and this is the dose. And this is a very nice trial, shows that if for patients with acute pulmonary embolism who receive thrombolysis versus non-thrombolysis, we can find that low fertility rate with the thrombolytic syrup. So, what are the guideline recommendations for high-risk patient with pulmonary embolism? First of all, it is recommended that anticoagulation with unfractionated heparin, including weight dose adjustment, class 1C. Systemic thrombolytic syrup is recommended for high-risk pulmonary embolism or acute massive pulmonary embolism, class 1B. Surgical pulmonary embolectomy is recommended for patients with high-risk pulmonary embolism in whom thrombolysis is contraindicated or failed. What are the treatment of acute phase? Again, when oral anticoagulation is indicated in patients with pulmonary embolism who is eligible for NOAC, use NOAC. Whatever you like, you have apixaban, dabigatran, adoxaban, or rivaroxaban. NOAC is recommended form of anticoagulation treatment. It is class 1. So it should be the gold standard for us. Again, the multidisciplinary team for management of high risk and the selected case of intermediate risk should be considered depending on the resource and expertise available. Class 2A, ECMO may be considered in combination with surgical embolectomy or catheter direct treatment in refractory circulatory collapse or cardiac arrest. Again, another recommendation for acute phase treatment for high-risk patient, percutaneous catheter direct treatment should be considered for patient with high-risk pulmonary embolism when thrombolysis is contraindicated or failed, class 2A, C, norepinephrine, dobutamine in patient with high-risk pulmonary embolism or cardiogenic shock, and the ECMO again, as we mentioned. What about long-term chronic treatment and the prevention of recurrent patient without cancer? Indefinite treatment with vitamin K antagonist is recommended in patients with antiphospholipid syndrome, class 1. Extended anticoagulation should be considered for patients with no identified risk factor for index pulmonary embolism event, class 2A. Extended anticoagulation should be considered in patients with persistent risk factor other than antiphospholipid syndrome, class 2A. Extended anticoagulation should be considered in patients with minor transit reversible risk factor for index pulmonary embolism, class 2A. Reduced dose of apixaban or rivaroxaban should be considered after first 6 months. So this is very important. So you have to give the full dose for first 6 months, and after that you have to reduce the dose. So what are the long term? This is very important. We have to make routine clinical evaluation is recommended 3 to 6 months after acute pulmonary embolism. Integrated model of care is recommended after acute pulmonary embolism to ensure optional transition from hospital to ambulatory care. This is very important. It is recommended to refer symptomatic patient with mismatch perforation defect in VQ scan beyond 3 months after acute pulmonary embolism to what? To pulmonary hypertension and to exclude the staff expert center to be careful that the patient doesn't receive staff. Pulmonary embolism in patient with cancer, edoxaban or rivaroxaban should be considered, class 2A. NOAC, of course, are contraindicated during pregnancy. Rescue thrombolytic therapy, we know already for patient deteriorate hemodynamically. So to summarize, this is what you have to do with any case of pulmonary embolism. What suspect, based on clinical prescription and the past medical history, check the likelihood of pulmonary embolism, Geneva rule or Willis rule, this is very important, diagnostic workup, D-dimer, ECG, CT pulmonary angiography, echo, risk stratification, very important, hemodynamic stability, base score, RV dysfunction, troponin level, and treat anticoagulation, thrombolytic therapy, and surgery. Thank you so much for your attention.